Thank you very much. Good afternoon. The NICE Clinical Guideline 177 deals with the management and treatment of osteoarthritis in adults. It deals with both the pharmacological and non-pharmacological treatment of osteoarthritis in adults. The baseline or the core treatments they say we should try and undertake are things like weight loss, manual therapies and exercise. Moving on to the pharmacological treatments, they say that first of all you should try oral paracetamol and or topical non-steroidal anti-inflammatory gels. But more important, this clinical guideline actually says that if someone is suffering from biomechanical painful joint pain, they should be considered for bracing support or insoles. This is a guideline that actually mentions insoles. It also goes on to mention that if they're suffering from moderate to severe arthritic joint pain, they should be considered for an intra-articular corticosteroid injection. So with that in mind, if a patient comes into our clinic, we suspect TMTJ arthritis, we send them for the appropriate imagery, AP and lateral weight-bearing x-rays, a medial oblique non-weight bearing. We look for the obvious signs of arthritis, a reduction in joint space, subchondral sclerosis, cysts and osteophytes. If they're amenable, we'll list them for an injection. At the same time, we will also initiate orthotic therapy. What we're looking for in an orthotic, of course, is stabilization of the joint, some cushioning, some control if needs be. Of course, as podiatrists, to be able to do these injections, we need to have done the appropriate training to get your society insurance. I know that there are some master's modules on injection therapy, and I know some of the podiatric surgeons do this training. I think it's important to make sure that there's someone at the end of the training that can assess you for your 10 competency injections, because a lot of people have been having problems. They'll pay for an expensive course and then they can't get the 10 injections signed off. So you need to make sure you can get that done. Of course, if you qualified as a podiatrist post 1980, you should have your POM-A annotation on your HCPC registration, which enables you to inject local anesthetic and depomedrone or methylprednisolone into a patient, as well as some other drugs as well. Also, POM-S, if you qualified post-98 or if you've done further training, there's some handy drugs on there that you can stock, sell, or give to your patient, such as codidromol, cocodamol for pain, codeine phosphate. Also, if you've got problems with post-injection infections, you've got amoxicillin, erythromycin, and flucloxacillin that you can supply. We also, as a profession, can now be independent prescribers. I became one earlier this year. It has definitely improved my practice. I would recommend that as a profession, we should embrace independent prescribing. It puts us on another level. So this is something we should all look at. Surgery is not the enemy. Surgery is sometimes a first port of call for arthritis within the foot. However, if the patients, if their symptoms don't warrant surgery or they do not want surgery, we've got to be able to offer them a treatment option. And I'm finding anecdotally, I do a lot of these, I get a lot of referrals, that it's a very good treatment. And I see them on a 6-monthly basis, some patients. But you've got to make sure that you tell the patient that this doesn't solve a problem. Make sure you're friends with surgeons, so you've got a conduit of referral on. Contraindications, this therapy is not for everybody. People with severe coagulopathy, unstable joints, inaccessible joints, if they've had the surgery or this kind of treatment before and they've been non-responsive, osteochondral defects don't do well with injections. And of course, if the patient is severely needle phobic, you want to keep them away from needles, basically. Of course, as well as hopefully being a therapeutic treatment, there's a diagnostic element to injection therapy. If you inject an overtly arthritic joint and you get no relief from the pain whatsoever, or should I say the patient doesn't get relief from the pain, then it may be time to cast your diagnostic net a little bit wider as there could be something else going on. You'd expect, at least for the duration of the local anesthetic, to get a reduction of pain. So it is a diagnostic tool as well. What we use a mixture of lidocaine and depomedrone. The reason why we use this, it's based on pretty good evidence. There was a paper from 2009 by P.J. McMahon et al. It is titled Injectable Corticosteroid and Local Anesthetic Preparations, a Review for Radiologists. What they discuss in this paper is the fact that corticosteroids actually contain corticosteroid esters, which are highly insoluble in water-based products, such as local anesthetics. These esters cause microcrystals, but what this paper showed is that these microcrystals do not have a great propensity to aggregate or change size in lidocaine. So lidocaine came out well. It also came out well in an animal model of testing against bupivacaine, and they said that lidocaine has got a 4 times less chance of causing generalized convulsions in a patient than bupivacaine. So two good drugs. And it also said, this paper, that triamcinolone or Kenalog is more likely to cause soft tissue atrophy than is depomedrone or methylprednisolone. So that seems a good idea to co-administer the two drugs that came out on top. And they are both on the POM-A on the sheet. So that's helpful. The method, I do these in a theatre environment. I've got either an image intensifier, these are all pictures from a list I did, image intensifier, or a mini C-arm. I always give a proximal block. It sounds daft, 2 injections. It's not. If you go directly into an arthritic joint, it's a bit unkind, I think, and it's bloody sore. So if you can give a proximal block, I give a proximal block. Once I've given the proximal block, aim for the second or third TMTJ, because we're talking about second and third today. Well, I am. And they share a capsule. So I use a 27 gauge needle or a short spinal needle. I do an arthrogram using 300 omnipaque fluid. That is not on our POM-A list. I get round that in our hospital by doing an expansion of practice documentation. And so I'm covered by their vicarious liability to do these injections. Once I know I'm accurate and happy and I'm in the joint, that's a 27 gauge needle, that's 300 omnipaque, that's an arthrogram into the second, and hopefully traveling over to the third. Then I'm happy to put in the corticosteroid, and then hopefully the patient's happy as well. And honestly, giving a nice block first makes it a lot more comfortable for the patient. Of course, with any invasive therapy, any monkey can shove a needle into a patient. You've got to be aware that there can be side effects. Local side effects such as septic arthritis. You can have a steroid flare-up for a couple of days. You can have soft tissue atrophy. You can have tendon rupture, because apparently it's because of the inhibition of proliferation of tenocytes. Further cartilage damage. Remember, a patient's going to go away with a nice foot that feels a lot number, and the corticosteroid can have up to a 6-month effect. They use it as normal. They're advancing their arthritis. And as well as local side effects, you can have systemic side effects. You can have facial flushing. It can affect glycemic control, this therapy. It can lower the ESR and CRP levels. Uterine bleeding has been reported. And of course, rare but can happen, anaphylaxis. More recently, it has been reported that something called central serous chorioretinopathy has been reported, and this is quite a recent thing, and it's a buildup of fluid behind the retina in the eye, which distorts vision. So it's an only injection, but it can have serious consequence. Time's up. All right. Thank you. So I didn't see you.